Action Research Program in our Research in Progress webinar series. My name is Glenn Mays. I'm a professor here at the University of Colorado, and I direct the National Program Office for the Systems for Action Research Program. If you are new to this webinar series or to our program, I'll take just a moment to orient you a bit. Systems for Action is a national research program funded by the Robert Wood Johnson Foundation. And our mission is to study and test new ways of helping to align medical care, public health, and social service systems in ways that can improve health and advance health equity. So we are a research program, and we study a whole variety of ways of helping medical, social, public health systems work better together, align their resources, goals, activities, and strategies in ways that can achieve higher levels of health improvement and, importantly, help to advance health equity, particularly for historically marginalized and underserved populations. We study innovations in system alignment or system alignment strategies tested in communities all around the country, in rural and urban settings, and tribal settings, in many different geographies all around the US. And of course, we come to you regularly, about twice a month, with this webinar series to showcase one of our funded research studies and give you a chance to peek behind the curtain at the research and to find out more about what we're learning about strategies for aligning systems and help us collectively move these types of findings and lessons learned into action across the country. And today is, in keeping with that mission, we're going to be featuring one of our really exciting recent grantees and research teams funded by Systems for Action, a team based in Ohio, led by colleagues at Ohio State University. We'll be hearing from Dr. Alicia Bunger and her colleague Elizabeth Solinger, talking about their project, and particularly an interesting platform for disseminating findings and lessons learned about how to implement strategies for aligning systems and helping to facilitate collaboration across systems. Before I turn it over to our speakers, though, just a couple of logistical notes. We will have time for questions from the audience today. And so we do have a large number of participants. So we ask that you use the Q&A feature on the Zoom meeting today to type in your questions, and you can do that at any time during the webinar. Look for that Q&A box down at the lower right-hand side of your screen. Click on that at any time. Type in your question. We'll get to as many of those questions as we can during the latter part of the session today. If for any reason we don't get to your question, we can also follow up with you after the webinar to make sure your question gets answered. Also of note, we do record these webinars and archive the recordings on our research program website. So a day or two after today's session, you can find the recording of this webinar along with the slides and any collateral materials posted on our website. That website, of course, is systemsforaction.org. And if you register for today's session, you'll also get a notice about where to find those archived materials. One other note I'll mention is that we fund new studies and on a regular basis, and we currently have an open call for research proposals for groups and research teams that have an idea for an innovative way of helping to align medical, social, and public health systems. If you're ready to test that idea rigorously, at least on a pilot basis, to demonstrate feasibility and acceptability, our current call for proposals will be hopefully of interest to you. So I'll direct you to our website at systemsforaction.org for more information about our currently active 2025 call for proposals. And the deadline for submitting an application to that proposal is June 4th. So you still got some time, but definitely check that out if that's of interest. So, without further ado, I will turn it over to our colleagues, Alicia and Elizabeth, to step us through their work.
Thanks so much, Glenn, and thank you, Sedina, and all the Systems for Action folks for supporting us over the years. Thanks to all of you for tuning in today. Um, as Glenn mentioned, I'm Alicia Bunger. I work at Ohio State. I am a social worker by training. I'm also an implementation scientist, and I am passionate about collaboration across systems for coordination and quality care. I'm very excited that Elizabeth Solinger is joining us today. Elizabeth, do you want to introduce yourself real quick?
Yes, absolutely. Thank you for having us this morning. My name is Elizabeth Solinger. I work at Ohio State with Dr. Bunger in general internal medicine. I am a researcher by trade. I've been in the field for over 18 years. I'm very excited to be working in this realm with Dr. Bunger. Thank you for having us.
Well, this project, this series of projects have been a labor of love, and I emphasize the love part. And we're very excited to be able to share a little bit more about what we've been learning over the years. So I just want to begin by acknowledging collaboration, implementation, and research about those topics are truly a team sport. And we are here because of strong partnerships. And willingness to chew on some really thorny topics all together. And that's in partnership with the Public Children's Services Association of Ohio. They represent all 85 public child welfare agencies in the state. The Ohio Association of County Behavioral Health Authorities, they represent all 50 behavioral health boards in the state. The Ohio Council of Behavioral Health and Family Services Providers, which represent private behavioral health organizations across the state. Of course, the Robert Wood Johnson Foundation. And we also are able to leverage and piggyback on some work that we were doing that's also funded by the National Institute on Drug Abuse around collaboration and system alignment. Our research team, we have lots of different disciplines and lots of different institutions represented. And of course, we have benefited from those diverse perspectives and disciplinary training in the way that we approach our work and analyze our work. So very, very grateful for everyone's partnership over the years. We're going to start off. I wanted to offer a little bit of context about some of our research questions and what we learned about system alignment in our research study. And then importantly, this is what I'm going to kick it over to Elizabeth. I want to share a little bit about our plans and what we did to help package up our findings and share them out with our partners. And I hope I'm not I'm going to spoil the results. It wasn't what we had anticipated, but we learned a ton, not only about system alignment, but also about how we translate our findings into real world practice change. All right, so a little bit of context. Our work is centered at the intersection of children's services and behavioral health. And back in 2017, when our partnership with our state agency partners began, this was really the height of the opioid crisis. And the opioid crisis, as well as substance use or substance misuse issues in general, have had really devastating consequences for families, especially those that are coming into the child welfare system. We know that kids and families that come into the child welfare system because of parental substance misuse don't fare as well as families that come in because of other reasons. So substance misuse is also linked with a likelihood of child maltreatment. And so when these families come in, oftentimes kids and parents have about a year to work through their case plan before a judge makes a determination about whether to terminate parental rights or reunify the family. And if you've heard a little bit about some of the difficulties involved with accessing substance use disorder treatment, there could be a 6-month wait list just to get into treatment. And we know that recovery is a rocky pathway, and sometimes there's return to use. And so that 12 months goes real quick when you're on a wait list for 6 months, and then you have to be able to demonstrate some progress toward recovery to be reunified with your kids. And so we see a high rate of families not reunifying when there's substance misuse involved. So, to do something about this particular issue, the Sobriety Treatment and Recovery Teams model, which is a national model, is a child welfare intervention that's been demonstrated to be effective for quickly connecting parents with substance use treatment when they enter the child welfare system, connecting them with a family peer mentor, so someone with lived experience of both recovery and child welfare experience. Quick connection with a substance use disorder assessment, and 4 behavioral health service visits. And this chain of events is supposed to happen in 38 days. And when it happens that way, parents have great outcomes, kids have great outcomes. And back in 2017, Ohio wanted to implement the START model. And here in Ohio, it's implemented as sobriety treatment and reducing trauma, to honor the origins of this model in Ohio and the emphasis on child trauma that's also linked with substance use issues within the family. So when we implement this model well, we get great outcomes. But the type of model that this requires, in order to make those quick connections to substance use disorder treatment, and in order to align case plans, in order to get families connected with a family peer mentor, there needs to be collaboration between the Child Welfare Agency, which is usually, at least in Ohio, a public county-based governmental agency, and in collaboration with a private behavioral health treatment facility. And so those could be public or nonprofit, or those could also be for profit, but there needs to be a partnership there in order to make those quick linkages. So when we started working together, and START got initiated by the Public Children's Services Association here in Ohio, there were a lot of questions about what kind of collaboration does it take to implement START, at least here in Ohio. And we know that those relationships are really important. And we actually think that those collaboration strategies are implementation strategies. But we also know that that collaboration, especially between public and private organizations, child welfare and behavioral health, which have different types of regulations, expectations, data sharing requirements, we know that that can be really challenging. And then to throw another factor into the midst, in Ohio, we have a county-based system. And so we have some very urban environments with robust service delivery systems in the behavioral health space, but we also have rural and Appalachian communities with far fewer treatment services that are available. And so we know that that collaboration can look differently. And on top of it, what exactly does it mean to collaborate? So one of the first things that we did, and I'm getting to our Systems for Action project here in a second, we began, and we were funded through the National Institute on Drug Abuse to specifically examine those collaborative relationships between the public child welfare agencies and their substance use treatment facility partners within each of the counties. And we wanted to be able to specify exactly what are the ways in which these agencies are collaborating, and can we figure out which methods of collaboration are linked with better implementation, and then help agency leaders collaborate better. And so in the true spirit of community engagement, we were talking with at the time, the executive director of the Ohio Association of County Behavioral Health Authorities, Sherry Walters, who's retired now. And Sherry said, we were talking about how challenging it is sometimes for the child welfare agencies to be able to identify the behavioral health organization that they should be partnering with. They didn't necessarily know all the providers that were out there. They didn't know which ones had the services that parents that were involved in the system might need. They didn't know which ones might offer the best array of services, the ones that were linked with the highest quality. Um, and we were in this meeting, and God bless Sherry. Sherry goes, you know what? They should really be reaching out to their ADAM-H boards. And ADAM-H stands for Alcohol, Drug Addiction, and Mental Health Boards. And these are boards, we have 50 of them in the state. So most of them cover more than one county, but they're responsible for local behavioral health planning. They do a lot of needs assessment work, agenda setting, advocacy. They also allocate regional funds for behavioral health services. A lot of our counties have tax levies that lead to a set aside for behavioral health funds. So these ADAM-H boards are organized around the state. And so if you think about it, these behavioral health boards perform the public health functions that our public health agencies do in the way that they set agendas, they do planning, they do resource allocation, and they do follow-up. And so these are centralized quasi-governmental agencies. They manage local networks of behavioral health providers. And it got us thinking, Sherry's comment got us thinking, like, well, if they should be reaching out to these ADAM-H boards for help, what happens when they do? Do we see better collaboration when boards are involved? How do boards get involved? Do we see better implementation as a result of that involvement with boards? So that led us to ask the questions that led to our Systems for Action grant. And so using these two grant funding mechanisms, we were able to ask these questions about how do child welfare agencies collaborate with behavioral health treatment providers? And then how does involving these third-party public behavioral health entities, how does that foster system alignment? Does it foster system alignment, and does it make a difference? And then can we take what we learned from this and help our counties collaborate better and implement the START model at a higher degree of fidelity? So this is a map of Ohio. We have 88 states. We have a proud tradition of home rule. And at the time that I made this particular map, Ohio START had rolled out to 3 cohorts of counties. Right now, the Public Children's Services Association is recruiting for their 8th cohort. So START has expanded to 56 counties and counting here in the state. When we originally recruited for our NIDA and our RWJF studies, there were about 36 counties that were implementing, and we recruited 17 of them. And these were in the first 2 cohorts of counties that were implementing the START model. Most of these counties were in the southern region of the state. So the ones that we recruited for the study have a star on them in this map. Most of these were small, rural and/or Appalachian regions. So we do have urban and suburban areas here in Ohio, but by far, most of our counties are smaller and rural. At the time that we made the slide, there were 330 families that were being served by START when we were doing the study, and today they've served over 2,000. So it's amazing to see how the program has grown and the potential utility, we thought, of our findings for improving implementation and collaboration. So our original studies with our 17 counties across those 2 different grants, we gathered a ton of data. This was a naturalistic multiple case study design. We gathered formal partnership agreements, including contracts and memorandums of understanding, and we did an in-depth analysis of contract language. We also did small group interviews in each of those counties with representatives from the Child Welfare Agency, the Behavioral Health Treatment Partners, and the ADAM-H boards. We came together for a series of collaborative group meetings where we reviewed the data, we reviewed the findings, and started to develop contents of our toolkit, which is how we decided that we were going to try to disseminate our findings and improve collaboration practice. We also drew on case records for Ohio START families to understand the degree to which the model was being implemented with fidelity and timeliness. We also did a series of surveys and gathered epidemiological data to understand the context for implementation and systems alignment. And then we integrated it all using coincidence analysis. And I have to I have to give a shout out to Emmeline Chung, who's a professor at UC Berkeley. This is her area of expertise, and she can explain all the mechanics behind it. I cannot except just bow down to her. It's based on Boolean algebra, so it's not like what we're trained to do in statistics class and PhD school, but it's really optimized for small samples. Because even though we've got 17 counties, when we're looking at this phenomenon at the county level or at the regional level, our sample's actually really small, even though there's so much depth to what's going on. So what the heck did we learn? So we learned a ton over the years. So the first thing that we identified, our original question that we had pitched to the National Institute on Drug Abuse was exactly how are child welfare agencies collaborating with public behavioral health treatment services? And so we identified 7 different ways or 7 different forms of collaboration. And so we had 3 different forms of collaboration that served to staff the program. So at the administrative level, folks were contracting out for services or contracting out for specialized expertise. They were contracting out for that family peer mentor position. Child welfare agencies were co-locating family peer mentors and other folks from the behavioral health agencies within the child welfare system. And they were also working through opportunities for joint supervision, particularly for that family peer mentor position. Sort of at the meso level, we saw lots of examples of how folks were trying to promote service access. And this took the form of coming up again using a memorandum of understanding to negotiate an expedited service access agreement. So an agreement between the child welfare agency and a substance use treatment provider that when we get a parent in through Ohio Start, they are going to be seen within a certain number of days. They're going to get into treatment within a certain number of days to make sure that families could make that timeline that was specified by the START model. There was also attention given to negotiating referral protocols so that frontline workers knew exactly what kind of information they needed to share with their behavioral health partner. And then at the frontline level, we saw 2 forms of collaboration for aligning case plans. And this occurred with shared decision-making meetings, getting everybody around the table along with parents and family advocates to make decisions, review case progress, and decide about next steps. And then, of course, data sharing, which is everyone's favorite thing to do. There's like a whole other webinar based on that. So we found these 7 different strategies. We also learned a lot about how difficult this work can be at every single level of the systems. Some of the major facilitating factors was strong leadership, particularly on the child welfare agency side. Having prior experience with the partners. What was interesting was especially in our rural and Appalachian regions, these are agency leaders that sort of grew up together as professionals and they knew each other. And maybe they were new in their roles as leaders of those particular agencies, but they still knew each other and they still had a working relationship from previous roles. And that seemed to make a difference. We also heard a lot of challenges because these 2 systems have very different expectations and requirements. Behavioral health is governed by HIPAA data sharing expectations. Child welfare is not. Child welfare is focused on child safety. Behavioral health is focused on parent recovery. And those 2 can coexist, but sometimes they do. There's some tension between those 2 goals. So we heard a lot about those challenges. We also discovered that contract language matters. In our contract analysis, we found that counties that had more timely service delivery tended to have more language that specifically referred to collaboration and partnerships in the content of those agreements. So words like collaborate and partnership were usually used to describe shared goals and values. And counties that had that kind of language did better with their implementation. Now, the good stuff about the behavioral health boards. We also learned that there were 3 broad ways that boards were helping to align systems. And the first step was through planning efforts, especially at the start of implementation. I shouldn't use start of implementation because we have the START model. It's the beginning of implementation. Boards being involved in initial planning. So they shared general information, or they participated on steering committees to help provide advice and guidance to initial program implementation. We also heard in about 41% of our counties, it was about seven, that ADAM-H boards were helping to broker partnerships. And this could mean helping child welfare agencies figure out who is in the region that they could even approach to partner, or making or facilitating an introduction between those two agencies. And then we heard a little bit more rarely, we heard instances where ADAM-H boards were helping to resource program services for START participants. So whether that was helping to or contributing to the START program budget, or providing services, emergency services for START parents. So planning, brokering, and resources. So what exactly matters? Which strategies help improve implementation? Well, in M's coincidence analysis, we learned that it was actually this board involvement that was linked with better fidelity, particularly in situations when there was a high need in the community, but we didn't see as much leadership support on the child welfare agency side. So we think that, if we don't have strong leadership within the child welfare agency, which sometimes happens, there's a lot of competing demands, especially in these public agencies. That's no fault of anyone. But when we do have those conditions, having that influence and that support from boards might really make a difference, for these types of programs and for helping to support system alignment. So, the moral of the story is everyone needs a Sherry Walter from the Ohio Association of County Behavioral Health Authorities, in their phone book, so that they can call, and everyone needs to have a conversation with a person like Sherry, because she was right all along. So what did we do with all of this? Well, we had a lot of conversations with our partners, and we analyzed these data and shared these results back in continuous conversations. But we wanted to share this out more broadly and sort of wrap up these findings. We wanted to be useful, but we didn't exactly know how to be useful. And one of our partners had recommended we create a decision support guide or a toolkit. So that's what we did. So through a series of participatory meetings, we gathered together our findings, and we tried to package it up in ways that we thought were useful. Originally, we thought our toolkit was going to be for child welfare agency leaders, since they were the ones that were often leading or initiating collaborations. But over time, our partners at the Public Children's Services Association began an implementation technical assistance program where they brought on TA providers to help coach these counties around all things START implementation. And Elizabeth is going to share a little bit more about exactly how they foster that collaboration across systems and help foster system alignment. But we realized pretty soon that it was actually the TAs who might end up using a toolkit and other types of resources like this. So we shifted our target audience to these TA providers. We sent it back to the TA providers. They reviewed, they offered suggestions on content, formatting, what they wanted to see, and we made a PDF. So, and that, we were like, oh, maybe we could try something cool online or some online learning modules. And our TA providers, Elizabeth's going to talk more about that. Pretty early on, they were just like, we want something we can hold in our hands. So we're like, okay, well, I guess, we can put a PDF up there and we'll print out a bunch of copies as well so that you can have it. If you're interested in seeing it, you can scan. Hopefully I did this right. I might not have. You'll have to let me know if I didn't. But you can scan that QR code there or go to our website, and see it for yourself in all of its PDF glory. But essentially, our toolkit has three main modules that correspond to our big buckets of findings. And so the first module is on those 7 collaboration strategies between child welfare and behavioral health. And so for each of those strategies, we define what it is, we specify when and why you might use it. We give a quote from our interviews to illustrate how it could be used. So here's an example of what a page would look like. It's a lot of text. Our second module is a contracting guide, not just for contracts, but also for other types of formal partnership agreements. This was developed by Amanda Girth, who's on faculty at our Glenn College of Public Affairs and who has background and expertise in contract specification and contract research. And so came up with sort of a checklist to help folks think about the components of their formal partnership agreements and how to align their services using these types of agreement documents. And then our third module was about engaging behavioral health boards, where again, we talked about those three main buckets of engagement strategies. So then we were like, well, let's see what we did. Let's see if we got anything useful. And so now I'm going to kick it over to Elizabeth and let her tell you more about our pilot test.
Thank you so much. So to evaluate how TA providers support collaboration and how useful the CASPI Toolkit is, we used a mixed methods approach. We asked two main questions. One, how do TAs support collaboration during implementation? So we conducted a focus group with 6 Ohio Start TA providers to learn about their coaching strategies, challenges they help address, and how collaboration evolves across the phases. We use content analysis to identify the key themes there. And then 2, how useful is the CASPI Toolkit? So we surveyed 9 TA providers assessing acceptability, appropriateness, and feasibility using validated scales. The survey also included open-ended questions, and then that same focus group also provided qualitative feedback on the toolkit's design and potential uses. So by combining survey data with real-world insights, we gained a pretty well-rounded understanding of both the TA role and how to improve the toolkit's use and practice. And you probably want to know how that went. So I'd be happy to share our results with you. So what we learned is that collaboration coaching is ongoing and adapts across all phases of implementation. So TA providers tailor their support to meet teams where they are. In the preparation phase, TAs help teams understand the importance of collaboration, identify key partners, and begin building relationships. And then during the active implementation phase, coaching shifts and focuses on clarifying roles, improving communication, managing conflict, and engaging families in shared decision making. And then in sustainment, TAs help maintain those partnerships. They adapt to changes like staff turnover and reflect on their progress. They also promote regular regrouping and celebration to keep the momentum strong within the group. So the key message is that collaboration is dynamic and essential, and TA providers play a really central role in guiding it throughout the life cycle of implementation. So this slide highlights our survey findings on the CASPI Toolkit's design and usability from the perspective of the TA providers. So quantitatively, it scored pretty well, 4.3 for acceptability and then 4.1 out of 5 for both appropriateness and feasibility. But the qualitative feedback really explained why. The TAs valued the toolkit's clear, organized structure, which helped them approach collaboration in a systematic way. They appreciated the inclusion of real-world quotes and examples, which made the content relatable and really grounded in practice. The non-technical accessible language and glossary, which people loved, made the material easier to understand and share out. And finally, having both the printed, that PDF version, and the online accessible format was a major strength, supporting flexibility in coaching approaches and accommodating different learning and working environments. However, most TAs hadn't used it. Some forgot about it or weren't sure how or when to apply it during coaching. And for non-TAs, the toolkit's length felt a little overwhelming to them. But the bottom line is that the toolkit is strong, but to make it stick, we needed better onboarding and practical usage guidance. We also asked TAs to rate how relevant and usable the collaboration strategies in the toolkit are. Shared decision making came out on top, which was obviously not a surprise to us. Data sharing and expedited access were also seen as highly important. Other strategies like contracting out and co-location were ranked a little lower, but not because they weren't valuable, more so because they were less timely and harder to influence directly in the TA role. And that gave us insight into where to focus TA energy and how to tailor tools to what providers are really ready to support. In the focus groups, the TA providers were excited about the toolkit once they revisited it, which was great to hear. They described it as something that could help them organize their coaching sessions and guide team conversations and really ensure consistency in what they were doing. However, most admitted that they hadn't used it yet. Some even forgot that it was available. And this wasn't out of lack of interest that we learned, but about lack of integration. They ended up offering practical ideas for how they would use it, assigning sections for team prep, sharing those checklists during meetings, and even using it as a reminder for themselves about what to do and when. So this showed us that once people see the toolkit fits into their day-to-day, they were really eager to engage with it. So why the gap between interest and use then? The initial rollout was a short virtual overview, and we learned that it was not enough to convey the value or build habits. Some participants didn't know how to fit it into their workflow or whether it was meant for teams or just for them personally. But revisiting the toolkit during the focus group really led to a shift. They started generating their own ideas for use, and the momentum certainly grew. So this tells us that multiple exposures and implementation guidance are essential. A toolkit, even if it's great, can't really speak for itself. So building on the user feedback, our next steps focus on both format and dissemination. We plan on creating brief, focused one-pagers that summarize each strategy, and these can stand alone or supplement their coaching. We're also planning to rethink how we introduce the toolkit. It might be a more interactive session or provide examples or even some type of starter guide targeted at the TAs. And we're also exploring how we might be able to generalize the content beyond Ohio Start, as many of these collaboration strategies are useful in other cross-system work. The toolkit's foundation is really strong. Now it's just about expanding its impact. To wrap up, we learned collaboration isn't a box to check. It is truly the heartbeat of implementation work. TA providers are constantly coaching on it and adjusting based on the phase of implementation. And the CASPI Toolkit is really well aligned with those needs. But we've learned that it takes more than a handout to shift practice. And with deeper rollout, these one-pagers, better onboarding, and more exposure, CASPI has the potential to become an indispensable tool in the TA toolbox. So in conclusion, our study highlights that the CASPI Toolkit has strong potential to support technical assistance providers, especially in their work implementing these complex cross-system interventions like Ohio Start. TA providers are really essential in bridging organizational silos and helping teams collaborate across systems. The toolkit gives them this structured, practical resource to guide that work. However, we also learned that having a good toolkit isn't enough on its own. If we want TAs to use it consistently and effectively, we need to go further in supporting how it's introduced and applied. By refining how we roll out the CASPI toolkit and embedding it into TA workflows, we can really better equip providers to strengthen collaboration, reduce confusion across systems, and ultimately improve outcomes for the families being served.
Well, thanks everybody for listening. Thanks, Elizabeth, for summarizing the last year of our experience with the toolkits. Like at the at the end of this multi-year process where there was COVID in the middle too. Like we have all these cool findings and we're like, all right, we'll do a toolkit. And then we're like, oh gosh, we actually have like that's only the first chapter of the next book is how to roll this out. So thanks for your attention, and we'd love to hear any questions or comments y'all have.
Fantastic. This is really inspiring work. And one of the many things I really love about this research project is that not only a really well-designed project to study, specific mechanisms to better align health and social systems for these populations, and looking specifically at governing board structures, which I think are often understudied when we think about systems and ways of helping systems work better. You produced some really important findings, but you didn't just stop there. You went the next step of actually, translating those findings into action, developing a toolkit that can actually help people utilize those findings in their own systems. And you didn't even stop there with developing your toolkit, but you actually tested your toolkit for usability and usefulness to your target audiences to make sure that your strategy for moving your findings into action, can be optimized and be effective there. So, yeah, so I just love what you guys did. It's amazing work and great lessons to all of us who want to be doing research in this area about how to align systems. And lessons in taking this research all the way through into actionable products that can actually help people take action in their own systems. So thank you for that. Again, we are open for questions. We have a Q&A box. You can type your questions in the Q&A box. You should see that box down at the lower right-hand side of your screen. And we'll get to as many of these questions as we can. And I'll start at the top. We have a first question asking asking more about your system intervention. Are the family peer mentors, are they certified family peers, or are there other types of the workforce that you're utilizing there?
So in the Ohio START model, all peers are certified peer recovery support professionals, and the ones that are hired for START are also selected based on their involvement previously with the child welfare system.
Fantastic. That is very helpful. Um, and we had a question about just linking to your toolkit on the website. We'll get that link posted as well for everybody. Um, and so we'll take care of that. Um, and a question about the implementation aspects of your work. Given that most your partners are large institutions with great infrastructure and resources, what guidance can you offer for adapting your strategies to smaller organizations, community-based organizations, low resource organizations, I guess, that are looking to pilot similar types of approaches for aligning systems?
I love that question. Thank you, because that was one of the things that motivated this project is, we have a lot of research that's based in these urban contexts that have infrastructure and resources. And we think that collaboration and implementation look different in these different settings. So with the overrepresentation of small, rural, and Appalachian counties in our sample, we think that our findings are directly relevant to these types of organizations. And I think the take home message is that it's all hands on deck. Those hands might look different depending upon what community that you're in, but really getting everybody together around the table and trying to pitch in wherever they have resources. I think that's the key thing. That's how we adapt to these other resource communities. The other thing, and we have not tested this, so this is speculation. This is speculation. Maybe it is a testable hypothesis. Is that many of us have a sneaking suspicion that collaboration goes a little bit more quickly or goes a little bit better in some of these suburban or rural communities because there are fewer providers with fewer resources, but there are fewer people to have to figure out, are you my partner? And will we be able to work together? So it's easier to identify the key players to get them at the table. And, sometimes necessity forces our hand in different ways, and we figure it out. We figure out how to do this on behalf of our community, whereas that can be a little bit more challenging when you've got more players at the table.
Fantastic. Great question and great response. A question asking for a little more of insight into how you think the COVID pandemic may have affected your project. And you think the data that you collected would be different if you were to collect it now, and any other thoughts there?
Yes, I've repressed those memories because I believe we got our both of these studies kicked off. I think we got Glenn. I think our grant was initiated in May of 2019.
Mhm.
So we had just recruited counties. Um, in late 2019. We had just begun data collection in early 2020. This was qualitative data collection. And then when the pandemic hit, everybody just put a pin in it. No, these poor agencies were so overwhelmed because even though we were working from home, child welfare caseworkers were not. They were still out in the community. They still make home visits, even when there's a pandemic. So we put a pin in our data collection. Most of our data were collected in the latter half of 2020 and early 2021. So it was still height of the pandemic. And we did adjust our interview guides in particular to ask folks about how they think their collaboration changed and how their system alignment changed in light of the pandemic. Um, and most folks thought, like, well, first of all, I still have to go out and see my families. Um, I still have to talk to my partners. Again, in the rural counties, we heard examples of folks having, like, getting together outside in the parking lot that connected their two agencies together. So, like, there were still opportunities for that face-to-face communication, but just outside, and with a mask. Um, we also heard a lot about how folks tried to pivot as much as they could to online video conferencing, Zoom, Teams, to be able to continue to do that collaboration. Some folks were talking about how the collaboration was actually a little bit easier because it took the pressure off, especially in more rural communities that could be spaced out more. Instead of having to travel an hour to a meeting, spend an hour in a meeting, and then travel an hour back to go see the next case on your caseload, they could be a little bit more efficient and it wasn't as challenging to collaborate. I think the thing to keep in mind here was that they were not necessarily forming relationships on Zoom. These were folks that had already begun forming relationships, had negotiated these partnerships, and had started to work together, and now they had to pivot to Zoom. I wonder if if we would have very different results if folks were trying to establish initial partnerships over Zoom. Maybe I'm old fashioned, but I think that's really hard to do. You need the face to face. That's my opinion. So, did that answer your question?
I think that's a great answer and very good
Oh,
points. Um, Question asking about the number of people who expressed interest, enthusiasm, I think for the toolkit, but didn't end up reporting using the toolkit. Any thoughts you have about how people might be reminded or prompted to integrate the lessons from your study and to use the resources?
yeah, that is the million-dollar question, quite literally. It was interesting. We presented some of our toolkit findings at the Dissemination and Implementation Research Conference this past December, and we had in front of our presentation, we had a couple other folks that had also developed toolkits, and this was in different states, different contexts, different countries, even, and found the same thing. Like, we did this toolkit, nobody used it. So we were not alone. And we were all like, in hindsight, like, yeah, like, if you that it's built on the premise that if you build it, they will come. And that is not necessarily true. And I think we made an important pivot early on by identifying that that we didn't have the right user targeted, that it was really these TA providers. Um, I don't know what the solution is. We're going to continue to try to figure it out. And maybe that is by integrating this into the materials and the workflows of these TA providers. Um, I don't know. I don't know how to remind folks in real time. I don't know. If you have ideas, oh, and this is from Kelly. If you have ideas, I'd love to hear them.
Excellent. Excellent question. Um, another question from Priscilla asking, how did you define collaboration, and how do you deal with different people's different perceptions about what collaboration means?
Oh, yes. That was part of what our NIDA funded study was really trying to unpack because there's been attention to different forms and functions of collaboration. But in practice, like we just say collaboration, but they mean different things. And so our interview guide initially was really tailored to try to unearth those different perspectives. And that's how we were able to identify all those different types of collaboration strategies. And there are likely others out there that we might have heard about if we had asked different people, different types of organizational leaders, different types of frontline service providers. So we left the definition of collaboration up to our participants' interpretation and then tried to elicit that and try to refine that. I think now, if we were going, we've defined, let me see if I can remember it. We've defined collaborative implementation strategy as a deliberate method of aligning organizations to implement something new or something like that. So, and it could, it could have a different set of forms and functions as well. So clear as mud, right?
I think very good. I like that. I like that definition, and like how it connects to principles and concepts around implementation. So fantastic. Let's see. Natalie asked about sustainability of collaborations. How does your work offer any insight around how you sustain these kind of collaborations over time?
I think as a function of when we gathered the data and sort of the state of implementation that our partners were in when we were doing this study, there was a heavy emphasis on initial partnership formation and sort of that troubleshooting period, like you're up and running and now you're encountering all the bumps on the road and trying to figure those things out. Um, I don't think our research necessarily speaks directly to sustainment, but I can offer that based on what we've been observing with our partners, that the longer you implement, the more likely it is that a partner turns over. But maybe, leaders retire and somebody new comes into that position, or your point person, your counterpart at a partner organization leaves for a new position or they retire. And so there's a constant renewal process that I think Elizabeth talked a little bit about too. There's a constant renewal process I think that's needed or that we're seeing in these counties. There's also the very real possibility that at the agency level, the selected partner, like things are just not working out. And maybe that partnership is not serving the outcome that you hoped. And so sometimes there is a need to terminate a partnership and go a different direction too. So I think that it's a multifaceted thing. So sometimes partnerships should not be sustained. Sometimes there's a need to form a new one. But then with the partners and at the organizational level that do need to be sustained, there's that constant partnership reformation period as people leave. And we know that these are also systems with really high staff turnover. So it's a dynamic process.
Can I add to that,
That could
Alicia,
be the
if you don't
next
mind?
project. Oh, yeah, yeah.
Something else that we learned during our focus group is that, in particular with contracts, through the sustainment phase, people became very casual with their contracts, with these ongoing relationships. We went from paper to a verbal agreement, that there was less communication with these ongoing partnerships. And we think that that has some impact on the sustainment phase, that everyone just assumes we're all in the boat together, and that's not always the case. And so I think for maintaining those relationships and for the sustainment phase, it does take more effort. You can't have those assumptions, and having some more formality to it, I think, is really important.
Yeah. And that makes me think too about what we know about formal partnerships in the literature. We know that a lot of times these partnerships start off with more formal arrangements, and then as trust builds, we're able to relax those formal governance structures. We're able to let our partnership build and evolve off of the trust and more informal relational mechanisms. But I think it is something to keep in mind, like maybe sometimes you still do need those safeguards there, especially with so much turnover among leaders and frontline staff. I think that might be an interesting research question about, does having that formal partnership structure help sustain the partnerships or help um, keep these cross-system programs functioning really well.
Fantastic. Our next several questions all are asking about issues of financing and resourcing, meeting the financial and resource needs of collaborative relationships. I wonder if you can say more about what you've learned in that space. And I know
Mm.
you mentioned that the role potentially of boards in helping to resource these activities. So any more you can say about that, meeting financing and resource needs?
So our community partner, the Public Children's Services Association, they manage the financing for the Ohio Start program. And so I hope I don't butcher it, but I can try to share a little bit what I understand about how the money flows. So Ohio Start, so I think this collaboration began at these local levels because there was an influx of resources for the Ohio Start model. And so those resources initially came from our then Ohio Attorney General's office, who wanted to address the opioid crisis. Flash forward, our former attorney general is now our governor and has been consistently allocating resources for the Ohio Start model through different state agencies and really encouraging cabinet level individuals to support Ohio Start. So there is a lot of state level support and state level resources to support Ohio Start implementation. That is outside of the research project. That is all on the practice administration side. So I think so there's dedicated money for Ohio Start. As we start thinking about the future, there have been other resources that have been identified to finance the Ohio Start model. So on the child welfare side, back in 2018 in the omnibus budget at the federal level, there was I'm going to mess up the title, Families First. Oh gosh, the Families First legislation. So child welfare agencies can draw down federal funds for evidence-based parenting and behavioral health models. So the idea is that once we have we're continuing to build the evidence base for the START model so that these agencies are able to draw down money and continue to finance the Ohio START programs in their regions. And then of course behavioral health the behavioral health boards can also, as we've seen, help fill in some of the gaps. Interestingly, this was in our coincidence analysis with only 17 counties. So, again, small sample, but we looked initially to see if there were variations in board involvement and implementation outcomes based on whether there was a levy that had been passed that would specifically offer additional financial resources for behavioral health services. And we didn't see any patterns there. That's not to say that there aren't any, but at least in our data, that didn't rise to the top. So it's complicated, rated funding.
No, those are great observations and lessons learned. So, well, we are at the bottom of our hour, so I want to
Okay.
thank Dr. Alicia Bunger and Elizabeth Solinger for sharing with us their really important findings from this project and lessons learned. I know that it definitely continues to inform the work that all of us are doing around testing strategies to help systems work better together. So thank you so much for sharing with us your findings. Thank you to all of us for joining us today. Please remember, we do these about every 2 weeks. So join us in future weeks. You can find out more about upcoming topics on our webinar series on our website at systemsforaction.org. Thank you so much, everybody.